This conference will now be recorded.
Good afternoon, everyone. You tell me two things. Can you hear me or not? Number one.
Yes,
Say
sir.
yes, sir. Okay. Number two. Can you see the screen or not?
Yes, sir.
Okay. So can you see the cursor moving over the screen?
Yes, sir.
Okay. Okay. Thank you. So has anyone covered this topic previously? This anal canal anatomy? Hmm? Has anyone
No, sir.
previously? No? Yes or
No,
no?
sir. No, sir.
No. Okay, okay. So this anal canal anatomy is very important. You may get a question from this topic, and mostly I will be dealing with the surgical anatomy rather than normal anatomy. Surgical anatomy of the anal canal. Okay. So actually this is a very cumbersome topic and very difficult because anus, see whatever, see our body, for example upper limb, lower limb, that we can be able to see and we can study, but anus is not like that. Okay, so anus is a complex structure. And another thing is, so once a patient who have been operated for any anal condition or any anal disease in his lifetime, okay, repeated again if he gets operated, again if for the second time if he gets operated means it will be held to him. Okay, so any anal disease or any anal condition should be operated once in a lifetime only, because that area is like that. Okay, that part of our body, anal canal, is like that. So second time the all planes will be disturbed and it will be very difficult for a patient. Okay, psychologically also undergoing surgery for an anal disease for second time, the patient will be psychologically depressed. Okay, so always we should hope that if any anal condition comes to a patient, he should be operated only for once in a lifetime, because it is a very painful area also, because very sensitive nerves, okay, sensitive nerves will be there near the anal, outside of the anal canal. Okay, so now we will move into the topic proper. So whenever, not only this anal canal, so whenever a question given to you at your MBBS level, whenever a question is given to you, you should always skeletonize. To all MBBS students, I will tell this one only: skeletonization of the answer. That is, you need to put the proper side headings and you should write the matter. Okay, then only you will fetch a good marks. Okay, so whenever any topic comes to you, any short question or a long essay question or very short, you no need to bother, but very short answer, 4 marks or a 10 marks essay question, you need to skeletonize the answer. That is, you need to put a proper side heading and you need to explain in point wise manner rather than filling up the pages. Okay, rather than filling up the pages, you may think that filling up the pages, multiple pages, you will fetch more marks, but it will create headache to the examiner. Okay, so now I will start this topic. So see how I have skeletonized the answer. So whenever a surgical anatomy of the anal canal was given as the question, then you should be writing in the following headings. Number one is, so what is a surgical anal canal? What is surgical anal canal? What is anatomical anal canal? And number three, what is the shape of the anal canal? What are the relations to the anal canal? And the epithelial and subepithelial, that is the mucosa and submucosal lining of the anal canal. And outside to the mucosa and submucosa, there is a anal canal musculature, which includes the internal sphincter, longitudinal muscle, and external sphincter. Next, what is the blood supply to the anal canal, which includes the arterial drainage and the venous drainage. Next, lymphatic drainage, nerve supply to the anal canal, and what are the spaces around the anal canal, that is lateral to the anal canal. Okay, and the most important thing is the importance of a dentate line, which is also known as pectinate line. anatomical and surgical importance of dentate line. So whenever a question is given, if you write in these side headings, the examiner will be very much impressed. Okay, so starting we'll go. First topic is first is surgical anal canal. So what is surgical anal canal? You can see the diagram on the right side of the screen. So here you can see the surgical anal canal. It is the length of the surgical anal canal. So I will be describing each and every part because this anal canal is somewhat uh, difficult, but if you read it properly, then you will be able to understand easily. Okay, so nothing. This is the anal verge. What is the outer part of the anal canal is the anal verge. Okay, you can see these longitudinal folds. Okay, this line you can see the dotted line. So this represents the anorectal ring. This is represent the anorectal ring. That is, this is the upper one is the rectum. This is the anus. So between the rectum and the anus is the anorectal ring, which is represented by a dotted line here. So from this part, anorectal ring, to the anal verge. So the outside of the anal canal, only this part, very short, 4 to 5 centimeters. Okay, very short, 4 to 5 centimeters is the anal canal. That is the surgical anal canal. So surgical anal canal is 4 to 5 centimeters in length. It extends from the anorectal ring to the anal verge. Okay, that is the first thing. Next, what is anatomical anal canal? So there is a thing such as anatomical anal canal. Here you can see the left side of this picture. Here it is written anatomical anal canal. Anatomical anal canal is from the, here you can see a curved dotted line. You can see a curved dotted line. This curved dotted line is nothing but the dentate line or the pectinate line. Okay, from this dentate line or the pectinate line to the anal verge. Okay, from the dentate line to the anal verge, this is the anatomical anal canal. So it would be around 3 centimeters. Okay, it would be around 3 centimeters. So that is surgical anal canal and the anatomical anal canal, that you should remember. Okay, this is of very clinical importance is there, which I will tell you later. Okay, this you remember. Anorectal ring to the anal verge is the surgical anal canal. From the dentate line to the anal verge is the anatomical anal canal. So next, what is the shape of the anal canal? So what you are seeing here is a hollow. When it is dilated, it will be like this. But normally in any individual, it will be in a closed. It will not be always in open, in an open state. If it is in open state, then you will pass flatus and feces continuously. So it is always in a constant closed state. This is due to the tone of the internal sphincter muscle. This is due to the tone of the here is the internal sphincter muscle. So due to the tone of the sphincter muscles, the anal canal is always closed, and it will be appearing as an antero-posterior slit. It will be appearing as an antero-posterior slit. Okay, so that is it. Okay, next, what are the relations? So when you put the patient in lithotomy position or dorsal position, okay, with the with the legs wide open apart, and you take a section. Okay, when you take a section like this, coronal section like this, sorry, axial section like this, so you will see here, this is the anal canal. Okay, anal canal, anterior relations, posterior relations, lateral relation. So anal canal anterior relation will be, there will be urethra. In the male it is urethra. This is the membranous part of the urethra, and the bulb of the penis. Bulb of the penis and membranous urethra form the anterior relation of the anal canal. Okay, which is separated, these two are separated by a perineal body. Okay, these two are separated by a perineal body anteriorly, whereas posteriorly it is related to a bony point called as coccyx. Okay, coccyx. This coccyx is separated by a anococcygeal ligament. Anococcygeal ligament. Anococcygeal ligament. Okay, and lateral to the anal canal will be, there will be ischiorectal fossa. There will be ischiorectal fossa or ischiorectal spaces. Okay, bilaterally. So lateral relation is ischiorectal fossa. Anteriorly is the membranous part of the urethra in male. and the bulb of penis, whereas in female anteriorly it is related to the lower part of the vagina, okay. Posteriorly is the anococcygeal ligament, okay. So next side heading is mucosa, submucosa. So we go inside the anal canal now. So what will you see inside the anal canal? So there are linings. So you can study like this. So from the inner aspect to outer aspect, what are there? Okay. So inner aspect there will be a mucosa lining. Okay. See this black thing is there. This is the mucosa lining, the anal canal. So below it will be the lateral to mucosa is the submucosa. Lateral to it will be the submucosa, and lateral to the submucosa will be the covering. So this is not the part of the, this muscle is not the part of the anal canal, but it is covering the anal canal. Okay, it will be also included in anal canal, but it is encircling the anal canal. Okay, so you remember as mucosa, submucosa, internal sphincter, and this yellowish thing is there is the conjoined longitudinal muscle of the anal canal, and lateral to it will be the external anal sphincter. Okay, these is the components of the anal canal, from medial, from inner to outer aspect: mucosa, submucosa, internal sphincter, longitudinal muscle, and external anal sphincter. So coming to the mucosa, inner lining. So mucosa, what is the epithelial lining? So inner part of the mucosa, so the anal canal can be divided into upper half and lower half, or above the dentate line. See, you can see this is the dentate line, dotted line, above the dentate line and below the dentate line. What will be the differentiation? Okay, clinically also you can very much appreciate if you see a patient with a proctoscope. If you do a parrectal examination or you do a proctoscopic examination, you can well appreciate the difference. You can see the dentate line, you can see the a difference between the mucosa above the dentate line and below the dentate line. Okay, so the epithelial lining above the dentate line, usually it is columnar epithelium. Usually it is a simple columnar epithelium. So it is simple columnar epithelium. That columnar epithelium has been derived from the continuation of the rectum. Rectum is also lined by the columnar cells. So the anal canal is also lined by the columnar cells above the dentate line. Okay, so what is the color? Color of the mucosa above the dentate line is plum color. Have you ever seen a plum color? It is a plum color is reddish. Usually it is a blackish red, dark red. Okay, so that red color is due to the presence of internal venous plexus. These venous plexus, can you see this venous plexus above this dentate line? This internal venous plexus, that is the superior venous plexus. Okay, this is superior venous and inferior venous plexus. So these are the cause for the plum colored to the mucosa above the dentate line. Okay, that is the color, that is plum color. Next, what are columns of Morgagni? So you can see here, columns. Okay, previous slide also you can see here columns are there. Okay, longitudinal columns are there. So these are the columns of Morgagni. These are nothing but the mucosa will get folded. Mucosa will be foldings, have foldings like a speed breakers. If you see on a road, if there are multiple speed breakers, you can see like that only the mucosa above the dentate line of the anal canal will be folded into vertical folds. There will be around 6 to 10 vertical folds. These are the columns of Morgagni. These are also called as the anal cushions also. So why these folds are these folds contain the radicals of superior rectal artery. So superior rectal artery, each column contains the branch of the superior rectal artery. Superior rectal artery is a branch of inferior mesenteric. Okay, superior rectal artery, it contains a pedicle of superior rectal artery and superior rectal vein. Okay, superior rectal artery and superior rectal vein. So you will be knowing, you may be knowing, see, there are these radicals will be much enlarged at some positions, that is 3 o'clock, 7 o'clock and 11 o'clock positions. When you put the patient, see, when you put the patient in lithotomy or dorsal, so this will be the 3 o'clock position. Okay, this is 3 o'clock. If you put a clock, imagine a clock like this. So this will be the 12 o'clock, this will be the 6 o'clock, this will be the 3 o'clock, and this will be the 9 o'clock. So at the 3 o'clock position, 7 o'clock position, and 11 o'clock position, the radicals of the superior rectal artery and the vein will be much bigger when compared to the other vertical columns of Morgagni. So these are the primary sites of hemorrhoids. So these are called primary hemorrhoids or piles. So when these superior rectal artery veins get enlarged at this location 3, 7, and 11, these are called primary piles or primary hemorrhoids. Okay. So next is anal valves. So what are anal valves? What are anal valves? Here you can see anal valves. Anal valves are nothing but these columns of Morgagni are there now. So the bottom of the columns of Morgagni are connected with each other with the crescent-like folds. You can see crescent-like fold. It will be a crescent, like a half moon. Crescent-like folds will be there. So those are called anal valves. Okay. So what is the surgical importance of anal valves? See, wherever I will tell, I will be telling about surgery only. Okay, there is some surgical importance of anal valves. So, what is the surgical importance is when you pass hard stool, when the patient is having constipation, and when the patient passes hard stools. So, what happens is these anal valves get ruptured. The anal valves will get ruptured, and it will form a anal fissure which will be extending from the dentate line to the anal verge, longitudinal streak of ulcer, okay, from the dentate line to the anal verge. Okay, that is the cause for the anal fissure. Okay, fissure in anal due to the break of the anal tear in the anal walls due to the hard feces. It will produce a longitudinal tear which extends from the dentate line to the anal verge. Okay, so that is the surgical importance. Next, what are anal sinuses? So you have seen the anal valves here. Okay, above this anal valves there is a space, small pockets are there. Okay, small pockets are there. Those are the anal sinuses. Okay, these are the anal sinuses. Okay, so what is the importance of this anal sinuses is, see, you can see pockets are there. So whatever is there foreign body, such as we will be eating some seeds, or we will be eating some grape seeds, or we will digest it. Okay, those seeds will be gone, or the hard fecal matter may get lodged in these pockets. Okay, may lodge in these pockets and cause blockage of the opening. So anal sinuses will have an opening. Okay, that opening I will tell you later. Those openings will get blocked. So when the opening gets blocked, what happens? The secretions through the opening will be blocked. So what happens is there will be abscess formation. So I'll tell you, anal glands will be there in the submucosa. Those will be secreting through the anal duct. The anal duct will be opening into the anal sinus. So when this anal sinus that with that opening is blocked by the foreign body or the fecal, what happens? There will be retention of the secretions, retention of the mucin, and result in abscess formation. Okay, there will be no free drainage of the anal glands. Okay, that is the surgical importance of the anal sinus. So next is the anal glands. Okay, so here I will tell you, see, anal glands are usually situated at two places. Okay, one is the submucosa. See, here they will be situated, and another area is the in the intersphincteric plane, that is the between the internal sphincter and the external anal sphincter will be the anal glands will be situated. So through these anal glands there will be anal ducts and will be opening into the anal sinuses. Okay, it will have anal ducts which pass through the internal sphincter and they open at the dentate line at the anal sinuses. Okay, when form a depression at the anal sinuses, that depression is called as the anal crypt. Okay, that depression is called anal crypts. Those are called crypts of Morgagni. So columns of Morgagni are different from anal crypts of Morgagni. Crypts are the depressions where the anal duct open into the anal sinuses. Columns of Morgagni are different. They represent the vertical folds of the mucosa of the anal canal above the dentate line. Okay, so next is the dentate line or pectinate line. This is very important. Dentate line and pectinate line has a very anatomical and surgical importance. Okay, that I will tell you later. So this you can see is the dentate line or the pectinate line. It is an imaginary line. So it is an imaginary line at the level of the anal walls. Okay, an imaginary line which is not a straight line, which is a curved line. This you can appreciate when you do a parrectal proctoscopic examination also. Okay, so this should be identified before doing a surgery also. This should be identified. Okay, so that is the dentate line or pectinate. So what are anal papilla? Anal papilla are nothing but the anal papilla are the remnants of the anal membrane. Remnants of the embryological anal membrane. They are situated at the level of the dentate line. Okay, they are situated at the level of the dentate line. So they are the anal papillae. So then what is transitional zone or pectin? So now what all I have discussed is above the dentate line. What all I have discussed are present above the dentate line. So what is below the dentate line? So you can see that below the dentate line, you can see, there is a difference between the color. Okay, there is a difference between the color between the anal canal in the above the dentate line and below the dentate line. So this is called as pectin. So this layer, that is the dentate line to here you can see a line. Here you can see a line. Not this is not the anal verge. This is the anal verge where you can see the hair. Okay, there will be anal verge will have hair and sweat glands, whereas this line doesn't contains hair or sweat glands. So what is this line called? This line is called as white line of Hilton. This can be appreciated. This can be appreciated by palpation on parrectal examination. Okay, this is called white line of Hilton. Between this white line of Hilton and the dentate line is the pectin. Okay, this is stratified. This has a stratified squamous epithelium, whereas above the dentate line is simple columnar epithelium. This is plum colored in shape. This is somewhat white in color. This is somewhat white in color. Okay, and this pectin is tightly, this layer of mucosa is tightly fixed to the underlying muscle, by a tough connective tissue. Okay, this pectin. Okay, this white line of Hilton can be appreciated. This will be situated between the, see, you can see the internal sphincter muscle here and the external sphincter subcutaneous part. Between these two, you can appreciate the white line of Hilton. You can see, feel as a groove. Okay, when you put a finger in the rectum, sorry, when you put a finger in the anal canal near the anal wedge, you can see a groove like thing between the internal sphincter and the external anal sphincter. Okay, this is the white line of Hilton. Okay, next is anodome. Anodome is nothing but the from the dentate line to the anal verge is the anodome. So it represents see, anodome is nothing but what it is a sensitive structure, whereas above the dentate line it is insensitive to touch, pain and temperature, whereas below the dentate line the anodome is sensitive to the touch, pain and temperature, because it is somatic supply, spinal supply, whereas above it is the autonomic nerve supply. That I will discuss later. Okay, next, what is the next? Coming to the submucosa. So coming to the submucosa, see, here is the submucosa. So submucosa contains where location of the submucosa. Location of the submucosa is, see, you can see the submucosa here clearly. Where is it located? It is located between the mucosa and between the mucosa and the internal anal sphincter. So this will be the submucosa. So what are the components of submucosa? In submucosa, you will have vascular component. Around the vascular, connective tissue, supporting connective tissue, and muscle tissue will be there. Contents will be vascular tissue, connective tissue, and muscular tissue. Okay, then what is mucosal suspensory ligament? So here you can see this is the longitudinal muscle. Sorry, this is the internal sphincter. This is the longitudinal muscle. From this longitudinal muscle, it is sending multiple fibrous septa. It is sending multiple fibrous septa through the internal anal sphincter, and it is getting attached to the submucosa and the mucosa here. Okay, this is very important. So Mr. Park has defined this dense fibrous septa which are attaching to the submucosa and mucosa at the level of the dentate line near the anal sinuses is called as mucosal suspensory ligament. Okay, this mucosal suspensory ligament can be a differentiating features between the actually it is equal to a dentate line, that is above the mucosal suspensory ligament is the portal circulation, and below will be the systemic circulation. That I will explain to you detail in later slides. Okay, now you remember that the mucosal suspensory ligament are the dense fibers, elastic fibers, which arise from the longitudinal muscle which pierce the internal sphincter and gets attached to the mucosa at the dentate line near the anal crypts. Okay, that is the mucosal suspensory ligament, which is defined by Dr. Park. Okay, so next is the anal canal musculature. Next side heading is the anal canal musculature. See, anal canal musculature is very important. Okay, you need to remember these components. So how what are the components of anal musculature, what muscles are involved? Okay, first is the anorectal ring. So you can see here anorectal ring. So I have told you anorectal ring. See, I have told you these are the vertical columns of Morganini. I have told you anorectal, from the anorectal ring to the anal verge is the surgical anal canal. So what is anorectal ring or anorectal bundle? Anorectal ring or anorectal bundle is composed of 4 components of muscles, that is 2 muscles and 2 sphincters. So one is the puborectalis. Puborectalis muscle is a part of the levator ani muscle. Okay, see, this is the puborectalis. Okay, see, this is anterior. Actually, the anterior is pubis, or if you see from laterally, this is the pubic symphysis. And posteriorly, this is the coccyx. If you take a lateral sagittal section, if you see from the lateral aspect, it is the pubis and it is the coccyx. So this puborectalis muscle. Okay, this is the puborectalis muscle. Okay, so I will be discussing later about the puborectalis. And the second component is the external anal sphincter. The anorectal ring is formed by puborectalis, external anal sphincter, that is deep part of external anal sphincter, conjoined longitudinal muscle, and internal anal sphincter. Okay, these are the 4 components of an anorectal ring. This anorectal ring is very important. If you cut it, and if you cut that this anorectal ring, what happens is the patient will not have control over the defecation. Patient will not have any sensation. He will just pass without any voluntary control. So this anorectal ring is very important for humans. Okay, and this anorectal ring can be palpated when you put a finger inside. And if you put a finger 4 centimeters inside, you can feel like a thickened ridge on the posterior and lateral aspect of the anal canal. So this is the puborectalis muscle, very important. Okay, anorectal ring. So this puborectalis muscle will be a part of the pelvic diaphragm. Pelvic diaphragm is nothing but the levator ani. Okay, so levator, a part of the levator ani is nothing but the puborectalis. So there are other components of ileococcygeus, other components are there of levator ani, of which most important is the puborectalis. Through this ring, what rectum will be passing, vagina will be passing, all structures will be passing within the ring. Okay, so which is very important, and it is an important component of continence mechanism, and it maintains the angle. See, you can see the angle between the anal canal and the rectum. This angle is maintained by the puborectalis sling muscle. Okay, so normally it will be like this only. Okay, when the feces come, what happens, it will just relax. When it relaxes, then only it will come. So if it is like this, the feces will not come down. So when the feces come, it will relax and it will come down. Okay, so it maintains the angle between the rectum and anal canal, and the position of the anal canal, length of the anal canal, and angle of the anal canal depends upon the strength and integrity of the puborectalis. Okay, and this is supplied by the somatic sacral nerves. Okay, next is the external anal sphincter. See, here you can see external anal sphincter is usually a single muscle. Here you can see 3 parts, 1, 2, 3. Excuse me. So external anal sphincter is usually a single muscle, but it is divided into three parts by the transverse fibrous septae. Fibrous septae from the longitudinal muscle, which divides the muscle into three parts. That is, this is the deep part, this is the superficial part, and this is the subcutaneous part. Okay, those are the three parts, and this covers the entire anal. See, the entire anal canal is covered by the external anal sphincter, and these are nothing but the continuation of the levator ani fibers. See, you can see here, these are the levator ani fibers. This continuation of the levator ani fibers are the external anal sphincter, and these are striated. So you can see these are striated, and these are voluntary muscle. It is a voluntary muscle. That is, see, when you are in a public place, or when you are in a cinema hall, or you are in a outside place, whenever you get a feeling of defecation, what happens? You will not defecate there openly. You will be able to control it. You will be able to control it till you go to the restroom. Okay, that muscle, what is the main mechanism behind it is the external anal sphincter. It is a voluntary muscle. So whenever there is a feces coming into anal canal, there will be a sense of defecation, but you need to go when you are in a public place. There you will be able to control it. That is due to the external anal sphincter. So this is very important. Okay, it is a voluntary muscle. Okay, that is under your control. Okay, so when you cut the when you cut and see that, it will be appear as red in color. Okay, and it is supplied by the inferior rectal branch of pudendal nerve. Inferior rectal branch of pudendal nerve. This inferior rectal of rectal branch of inferior rectal branch of pudendal nerve supplies the sphincter urethra also. Sphincter urethra. That's why, so whenever you feel like defecation, then also you will pass urine, because both has the same connection. Inferior rectal branch of pudendal nerve supplies the sphincter urethra also. So whenever you pass urine, you will defecate. Whenever you defecate, you will pass amount of urine. Okay, this is the common nerve supply. Okay, next is the attachments. Attachments of the external sphincter. External anal sphincter. That attachment I will show you in a different figure. See, here you can see the attachments. Okay, this is the external anal sphincter. You can see anteriorly it is attached to the perineal body. Anteriorly it is attached to the perineal body, and some fibers are decussating, that is crossing and attaching to the superficial perineal muscles, superficial transverse perineal muscles. And posteriorly these fibers will form an anococcygeal ligament which will connect with the coccyx. Okay, these are the attachments of the external anal sphincter. Okay, next is the next component of the anorectal ring is the conjoint longitudinal muscle. So conjoint longitudinal, here you can see why it is called conjoint longitudinal muscle. Conjoint longitudinal muscle is one part is the rectum. The rectum outer layer, outer longitude, this is the circular layer of the rectum. This is mucosa, submucosa, circular muscle coat of the rectum, longitudinal muscle coat of rectum. This longitudinal muscle coat of the rectum continues down as the longitudinal muscle layer of the anal canal. And some deep fibers from deep fibers of the puborectalis will also come and join. So when these deep fibers of puborectalis and the longitudinal muscle layer of rectum join, it forms a conjoint tendon. Okay, this is the conjoint tendon. So it is located between the internal anal sphincter and external anal sphincter. This longitudinal muscle, when it goes down, it gives multiple fibroelastic fibers. You can see the fibroelastic septa, you can appreciate it well here. Okay, these are the fibroelastic fibers. Okay, see here you can see fibroelastic fibers which are extending from the longitudinal muscle, passing through the subcutaneous part of the piercing through the subcutaneous part of the external sphincter and attaching to what? Skin of the perianal area. Okay, these are called as corrugator cutis ani of Ellis. These fibroelastic fibers are called corrugator cutis ani of Ellis. Okay, and these longitudinal conjoint longitudinal muscle will give structural support. How it will give is, this is for sending multiple septae. Okay, it is sending multiple septae all around the anal canal, and it is these septa are also attached to the here mucosa and the submucosa also. So by sending this septa, it will be giving a structural support to both the anal sphincters and to the mucosa and the submucosa of the anal canal. So what is the action of this longitudinal muscle? What happens when you during the defecate? When you defecate, what happens? What happens is there will be widening of the anal canal. What is the action when the contraction of longitudinal muscle causes widening of the anal canal and shortening of the anal canal? Shortening in means length of the anal canal will be shortened, width will be increased, and there will be flattening of the anal cushions. So flattening of the anal cushions means these columns of Morgagni will be flattened, and it will avert the anal margin. It will be avert the anal margin outside. Okay, anal margin will be open like a flower. Okay, then only you will be able to defecate the feces. Okay. So that is the action of the conjoint longitudinal muscle. Next is the internal anal sphincter. Here you can see the internal anal sphincter. As I have told you, it is located between the submucosa and the longitudinal muscle, conjoint longitudinal muscle is the internal anal sphincter. And this is around, it is not covering the entire anal canal. As I have told you, external anal sphincter covers the entire anal canal. See, here it is covering the entire anal canal. But internal anal sphincter, it is only covering up to the white line of Filton. It is covering up to only the white line. Only upper thirds of the anal canal is only covered. The over one third, it doesn't contain the internal anal sphincter, because internal anal sphincter is covered by subcutaneous part of the external anal sphincter. Okay. So this is nothing but the continuation of the circular muscle coat of the rectum. Here you can see continuous the circular muscle coat of the rectum. And if you see different, you always differentiate and study. See, it is a continuation of the circular coat of the rectum. It is whereas external anal sphincter is a continuation of the levator ani. External anal sphincter is a striated. It is non-striated. External anal sphincter is voluntary muscle, whereas internal anal sphincter is an involuntary muscle. And external anal sphincter is red in color. When internal anal sphincter, when you see the fibers, they are pearly white in color. External anal sphincter is supplied by inferior rectal branch of pudendal nerve. It is supplied by autonomic nervous supply. Okay. Next, what are these NANC fibers? NANC fibers are, these are non-adrenergic, non-cholinergic fibers. Okay, these are non-adrenergic and non-cholinergic fibers which are supplying the internal sphincter. What are these? Is when you stimulate these fibers, what it happens is it will produce nitric oxide here. It will produce nitric oxide and it will cause relaxation. It causes relaxation of the internal anal sphincter. Why I am telling this is very important. So whenever a patient comes with a chronic fissure or acute anal fissure, okay, I have told you acute anal fissure. So in such case, what happens is there will be high sphincter spasm, high sphincter tone. That high sphincter tone is, this high sphincter tone is due to the internal anal sphincter. That internal anal sphincter tone will be very much increased. So it will not able to dilate. When the feces come also, it will not able to relax. Okay, it will not able to relax. So what we do is in anal fissure surgeries, a lateral sphincterotomy, lateral anal sphincterotomy. Sphincterotomy means dividing of the superficial fibers. Dividing, otomy means opening. Okay, we are dividing, we are not cutting, we are dividing the internal anal sphincter fibers. Okay, when you divide the internal anal sphincter fibers, when you stimulate it, it will produce nitric oxide. Okay, when it produces nitric oxide, it will cause relaxation. Okay, and Lord's anal dilatation, anal, if you do an anal dilatation also, the internal anal sphincter will be stretched, and this septa is there. Now you can see this septa will be broken. Due to that stimulus, nitric oxide will be produced and it causes dilatation, that is relaxation of the internal anal sphincter, and the sphincter spasm will be relieved. Okay, hope you understood what I have said. Okay. So next, so the four components I have discussed. Next, another thing I want to tell is there is this plane. Actually, there is a plane between the internal sphincter and the external anal sphincter. Here there is a plane. It is the intersphincteric plane. It is the intersphincteric plane. You can go directly into this plane, and this is avascular plane. Okay, you can go directly here, and you can drain the, usually I told you anal glands will be situated in the submucosal space and the intersphincteric plane. So any infection in the anal gland result in abscess formation. So you can go in this plane and you can drain the abscess also. Okay. And another surgical importance here is these anal gland situated between the internal and external anal sphincter in the intersphincteric plane. When these get infected, what happens? The pus will be situated in this plane. So the pus will track along the septa. The pus will track along the septa formed by the longitudinal muscle fibers and septa and will be occupying the ischiorectal space, or it will be coming and opening into the perianal to form perianal abscess. When it passes through the septa and go into the ischiorectal, it forms ischiorectal abscess. And if it is improperly drained or if it is spontaneously ruptured, it develops into fistula, which will have a connection. That fistula I will be telling you in the next class. Okay, then you, if you understand this anatomy, then you can easily understand the types of fistula and the treatment of fistula also. Okay, that is the surgical importance. So everything I am relating it to a surgical importance. So next is the blood supply. So blood supply usually is arterial, it is superior rectal artery. What I have told you is the superior rectal artery above the dentate line, whereas below it is the middle and the inferior rectal. Okay, the venous drainage is also the same thing. So upper half, you can see the upper half of the anal canal is drained by superior rectal vein. So I told you superior rectal vein is a branch of rectal artery, is a branch of inferior mesenteric. So superior rectal vein will drain into, obviously, into the inferior mesenteric. Inferior mesenteric will drain into the portal circulation by joining with the splenic vein. Okay, superior mesenteric vein, inferior mesenteric vein, splenic vein. Splenic vein and superior mesenteric vein will be joining to form the portal vein. So inferior mesenteric vein will be joining the splenic vein. Okay, so upper half above the dentate line, superior rectal vein will be draining into inferior mesenteric vein. So above dentate line here, what is a portal circulation, whereas middle rectal vein and the lower half below the dentate line will be draining into the internal iliac vein. So internal iliac vein is systemic circulation. Okay, so simple. Above dentate line is portal circulation, below is inferior mesenteric. Why here also very surgical importance is there. What surgical importance is there is any malignant tumor above the dentate line in the anal canal malignancy above dentate line, the malignant tumor cells spread via the superior rectal vein, inferior mesenteric vein through the portal circulation, reach the where? Liver. So any anal canal cancer above the dentate line, metastasis will be going directly into the liver. So below the dentate line, any malignancy will be going into the internal iliac vein, systemic circulation, internal iliac lymph nodes. Okay, lymph nodal spread. There is portal spread. So lymphatic drainage, see upper half above the dentate line, they will be, the lymph will be draining into the posterior rectal group of lymph nodes and the para-aortic group of lymph nodes. Whereas the below the dentate line, it will be draining first into the superficial inguinal group of lymph nodes, followed by deep inguinal, not first deep and followed by super. First the superficial will be involved, later by the deep inguinal. Okay, so next is the nerve supply. Nerve supply above the dentate line, I have told you, above the dentate line, it is supplied by autonomic nervous system. The autonomic nervous system, if you prick, if you cut, if you cauterize, if you put a diathermy also, patient will not have any pain, but it will be, patient will have a mild pain due to stretch of the anal canal above the dentate line. But if you cut or put a cautery or you incise the anal canal above the dentate line, patient will not have pain. Whatever procedure you do above the dentate line, patient will not have, because it is supplied by autonomic nervous system. Whereas below the dentate line, it is supplied by spinal nerve, somatic nerve supply, inferior rectal branch of the pudendal nerve, so spinal nerve. So when you, so patient will have sensitive to touch, pain, temperature, cutting or cauterization. So patient will have pain. If you put finger, patient will feel the sensation below the dentate line. Okay, above the dentate line, patient will not feel anything. Okay, So another important thing is, this is very important. So spaces. So what are the spaces? Usually all patients usually in our okay, in our area means in our Andhra or India, usually our patients will be coming with commonest thing is perianal abscess. Sir, abscess around the anus, perianal abscess, ischiorectal abscess. These are the commonest anal condition, perianal condition. Patients come to the surgical OPD. See here, you can see this. This also it is very easy if you understand, if you have some concentration here. So the spaces around the anal canal, they are divided into PIS. Okay, perianal, ischiorectal, supralevator. So here you can see this is the perianal. So this is the anal canal. So this is the perianal region. This is the perianal. So what does the perianal region contains? The inferior hemorrhoidal, external hemorrhoidal plexus. It has an internal venous plexus, external venous plexus here, and a subcutaneous part of the external sphincter. That is the perianal space. Nothing is there, nothing will be there. Okay, only external venous plexus will be there, and subcutaneous part of external sphincter. That is perianal space. What is ischiorectal? See, can you see this one? Ischiorectal. This is ischiorectal. This is a pyramidal space. It is a, this is actually a coronal section. It is a coronal section. You can see a pyramidal shape, okay, which has an apex. Here you can see the apex. Here you can see the base, okay. It has an outer wall, inner wall, okay. So if you take the relations of the ischiorectal, so this will be the ischiorectal fossa, and the most common site for the abscess formation, and it is the most common site for the abscess formation, okay. So how? So what happens? Sorry, what are the relations? So ischiorectal abscess, ischiorectal fossa relations. So apex, here you can see the apex. It is joined by the, this is the obturator internus muscle. This is the levator ani muscle. So joining of the levator ani and the obturator internus muscle with along with their fascia, here white thing is the apex. Here the base. What is the base? Base is formed by the, what is this white thing? This is white thing, nothing but the transverse septa. The transverse septa is nothing but the longitudinal muscle sends a thick transverse fibrous septa into the ischiorectal space like this, here and here, which is between the superficial part of the external anal sphincter and the subcutaneous part of the external anal sphincter. This is the transverse fibrous septa, okay. So this is for base is formed by this transverse fibrous septa, and apex is formed by these two joining of two muscles, and outer wall is formed by the obturator internus muscle along with the fascia. This is the obturator internus muscle along with the fascia. So this is the ischial tuberosity. So this just above the ischial tuberosity, around 1 to 1.5 inches above, within this obturator fascia, you can see some vessels and nerves. Okay, these are the internal pudendal vessels, pudendal nerve, and perineal nerve. This canal is called as Alcock's canal or pudendal canal. Alcock's canal or pudendal canal. This is very important. Why? Because see, whenever you patient ischiorectal patient ischiorectal abscess patient has come, you have put the patient in lithotomy position, and you give a, you usually how you drain an abscess, you will give a cruciate incision. You give a plus mark incision, plus like this, longitudinally and transversely you will give, okay, longitudinal incision, transverse incision. So if you extend the, you will give incision like this, and if you over dissect, if you put your finger and manipulate further, and if you injure these vessels, there will be what, pooling of blood. You will not be able to control, okay, because it will be directly connected to the systemic circulation. So while giving incision in the ischiorectal region, you should be very careful that you should not over manipulate or put the finger and dissect the locules and over dissect and reach the medial wall. So if you do that, what happens is you will be injuring these vessels and you will be in the trouble, because you will not able to control, because it were, those are deep structures and you will not be able to control with the artery forceps, okay. So that is the surgical importance, you should remember, okay. That is the ischiorectal fossa. So medially is by the wall is formed by the Alcock's canal or the pudendal canal with obturator internus and fascia, and inner wall is formed by the levator ani and the deepen the superficial part of the external anal sphincter. Deepen the superficial of the external anal sphincter, the inner wall. So this is coronal section. So what are the anterior and the posterior relation? Here you can see the ischiorectal fossa on either side of the anal canal. So here there is a urogenital opening. The urogenital diaphragm. This is the why it is the urogenital diaphragm. Urogenital diaphragm with transverse perineal muscle will be the anterior relation of the ischiorectal fossa. Whereas the posterior relation of the ischiorectal fossa is formed by the gluteus maximus and the this white thing is the sacrotuberous ligament. Posteriorly, it is related to the gluteus maximus and the sacrotuberous ligament. Anteriorly, it is related to the urogenital membrane and the superficial transverse perineal muscle. Laterally, it is related with the outer wall with the obturator internus and obturator fascia with Alcock's canal or pudendal canal. Inner wall is formed by the levator anal and the deep in the superficial part of the external anal sphincter. Apex is formed by these two muscle, levator anal and obturator internus. Base is formed by the transverse septa arising from the longitudinal. This you may be asked as a short note or a very short note as ischiorectal space. When a ischiorectal space question occurs, you need to tell about these boundaries, margins, importance of the ischiorectal abscess, drainage, and the Alcock's canal. Okay, next space is the supralevator space or the pelvirectal space. Okay, supralevator space is supra means above the levator. So this is the supralevator space. So what is the importance of the supralevator space? So any infection in the supralevator space can come like this here through the apex and enter into the ischiorectal space, and from the ischiorectal space any abscess is there can be trickle like this here along this into the supralevator. What is this like this like this? What is this one? That is called hiatus of Squalbe. That is known as hiatus of Squalbe. Through this hiatus of Squalbe, it will be the pus can enter from the supralevator to the ischiorectal or ischiorectal to the supralevator or supralevator to the ischiorectal. Another thing I have forgotten to say is this is left ischiorectal, this is right ischiorectal. So abscess can trickle or it will spread from this ischiorectal fossa to this ischiorectal fossa behind the what like this. See here this diagram you can see from this ischiorectal fossa to this ischiorectal fossa, it can the abscess can travel like this by piercing the anococcygeal ligament. By piercing the anococcygeal ligament, it will grow. So what happens? It will form a horseshoe shaped abscess. This is horseshoe shaped. See, this is the horseshoe shape. You can see this one. The curve U shaped curve is the horseshoe shaped abscess. So this horseshoe shaped abscess, if it is not spawned, it is not completely drained, or if it gets ruptured spontaneously by itself, it will develop into a horseshoe shaped fistula with an opening here and another opening here. It will form a horseshoe shaped fistula. There will be a tract in a U shaped tract with two openings here. That is horseshoe shaped fistula. That also you should remember. That also you should be writing when a question of ischiorectal fossa comes. Okay. So this is the then this is the last slide. Okay, this is very important, anatomical and surgical importance of dentate line. This may be given you as a short note or a very short note. Remember these points, or note down this point. This is very important. Okay, whenever they given as surgical importance of a dentate line, or they may give us simply as dentate line or pectinate line, then these points you should be able to write. So this dentate line or pectinate line is the forms the embryological watershed between the visceral structures above and the somatic structures below. That is number 1 point. Second point is the mucosa. The mucosa above is supplied by the autonomic nervous system. What I have told you, it is insensitive to touch, pain, temperature, cautery, and incision. Whereas the mucosa below the dentate line is supplied by inferior rectal branch of pudendal nerve, which is sensitive to touch, pain, temperature, incision, and cauterization. Okay. Next, third point is venous drainage. So above the dentate line, the venous blood will be drained into the IMV, inferior mesenteric vein, thereby directing into the portal circulation. Below, it will be draining into the internal iliac vein into the systemic circulation. Next, lymphatic drainage. Above, I have told you posterior rectal and the para-aortic group of lymph nodes, whereas below is the internal iliac group of lymph nodes. Next, above this dentate line, internal hemorrhoids. Internal hemorrhoids or primary hemorrhoids, what I have told you, 3 o'clock, 7 o'clock, 11 o'clock position. Internal hemorrhoids or primary piles will be developing above this line. Whatever hemorrhoids which are below this dentate line are called as external hemorrhoids, whereas above this dentate line are called internal hemorrhoids. And the classical positions are 3 o'clock, 7 o'clock, and 11 o'clock. Okay. Next, anal glands open into the anal sinuses at this level, not below this line. Okay, above this line, I have told you what are anal sinuses. There are the anal pockets above the anal valves. Okay, into that opens the anal glands through the anal ducts. Okay. Next, rupture of the anal valves. The surgical importance of dentate line is these anal valves are situated at the dentate line. Dentate line is nothing but the imaginary line at the level of the anal valves. So whenever I have told you, whenever there is a rupture of anal valves due to hard feces, it will result in a fissure in ano, which will extend from the dentate line to the anal bulge. So the last point is there are fine nerve endings at this line. There are fine nerve endings at this dentate line. So whenever the feces come and touch this dentate line, the fine nerve endings will be stimulated. Then you will be feeling a sense of passing the feces out. Okay, that will be under the voluntary control of external anal sphincter. So these fine nerve endings are present at the dental line. Due to this presence of the fine nerve endings, you will be able to appreciate that the hard feces have come into my rectum, into the anal canal. Then only I will be able to pass. Okay, so that is due to the fine nerve endings which are present at the dentate line. Okay, these are the important points. Okay, you should be able to write when a question of dentate line or a pectinate line as a question is given as a short notes or very short note. If you have any doubts, please tell me. Say yes or no. I think no one is there. Are you there? Any one of you? Hello? Can you hear?
Yes, sir.
Have you understood the topic? If you have any doubts, you can ask me. I think no one has having doubt. I feel that you may you have completely understood, or you may not have listened the class. Okay, there are only two variants here. Either you have completely understood or you have not listened the class. Whatever may be. Thank you for your patient listening. Close this.